Well, thanks very much, Dr. Hunt, and to the entire foot and ankle team. Those are very kind words. I don't know so much about expert, but I'm very interested in PRP and biologics in general, and I've done a lot of work in this area with a lot of ongoing studies, including collaborative studies with the foot and ankle section and Dr. Hunt in particular. So it's an exciting time to be looking at the field of biologics. And today is just going to be essentially a primer on what PRP is. I did make at least a couple slides applicable to foot and ankle specifically, but it's more about understanding PRP in general. So without further ado, we'll get going. And I do have to stop right at 8 because I have clinic, but I'm happy to take any questions through email, phone, text, whatever, and happy to join in any other time to chat more. I do have some disclosures, none of which are relevant to the content of this talk, but I do some consulting for companies that make biologic products, but I don't have any royalties or anything like that related to that. So as we all know, biologics in general, especially for OA, but in general, it's the hottest topic in orthopedic surgery, whether it's PRP or bone marrow or fat or whatever it might be. And I want to play this video. This is compliments of our partner, Dr. Drew. Hopefully the audio comes through. Let me know if it doesn't. But this is what our patients are seeing in the public.
I don't know about everyone else, but I can't hear.
Yeah, we're not hearing the audio there.
You're not hearing it? That's
No.
Unfortunate. So what this video is an undercover investigation of stem cell and biologic minute clinics, telling the public that these treatments can cure your joints, cure your bone on bone, cure your Alzheimer's, cure your Parkinson's, etc. And then at the end, one of the ladies who's undercover goes, well, my orthopedic told me that this is not the case, that these don't work as you say they do. And this woman here goes, well, who said that? An orthopedic surgeon? And she said, consider your source. So just kind of interesting in terms of what the public, and that means our patients, are hearing relative to what's truly available and applicable. And then we see these things all over in terms of PRP and stem cells and advertisements, just telling our patients, if you just take this product through a pill, a liquid, or an injection, you're going to turn this subluxated, dislocated, osteoarthritic joint into a normal joint. And that's, again, what our patients are hearing and seeing. But this is the main problem. And I know this also stem cells, and we're going to talk about PRP, but it all comes into play when we think about biologics, because quite frankly, our patients don't always know the difference between them. They just know that it's a shot that might get them better. And there's some real potential complications. We're running a registry right now nationally looking at complications with biologics, including PRP. And this was published in 2019, actually looking at stem cell shots, so to speak, and the complications and infections that they cause. So taking a step back, what do patients really want to know when we give these treatments? So they want to know, number one, how long does it last? How often do I have to get it? Can I return to everything I want to do? And if I do nothing, is that okay? Is it okay to live with that OCD in my talus? Is it okay to live with my Achilles tendinosis? Are those things okay? Or do I need to have my MRI findings treated? And that's the answer we have to answer that we have to come to with our patients. And the key is to manage expectations. So this is my pup Murphy. When we have a barbecue, his expectation is that he's going to get all that meat. In reality, this is what he gets. He gets a carrot because it's healthier and it's a better choice for him. So if a patient comes in wanting PRP for their Achilles tendinosis and their main goal is to run a 5-minute mile and they're currently running a 5:15, I'm not sure I can get them there. And that's the key, to understand what they want and what you're able to do with your treatment. So in terms of biologics in general, what's allowed? Well, there's a lot of nuance on this and some evolving FDA regulations coming even in this year. And it'll be interesting to see with the fast track of the COVID vaccine, how that changes things in the FDA for biologics moving forward. But essentially, what's allowed are FDA 361 HCT/P pathway products, which means that they're minimally manipulated and for homologous use. What does homologous use mean? Well, does it mean a mesenchymal cell is anything that a mesenchymal cell is? So fat can be put into muscle, or muscle can be put into fat, or should muscle be put into muscle and fat be put into fat? And then with PRP, it's blood. So if we're taking PRP from the peripheral blood and we put it into a joint, is that truly for homologous use? And we all think that it is, but you could find people who might think that it isn't. And so these are the definitions. These are things we need to know. We have to understand that at least in the US, outside of clinical trials, that the samples cannot be more than minimally manipulated. And there's some nuances with that too. What's minimal? And that's a very subjective word. And then again, only for homologous use. Unless you're in an FDA approved trial, or outside the US, because in some countries you can do these things cannot be done in the US with PRP or other biologics, including all of the things that you see here, but namely culturing cells. Can't do that here in the US. So what are our biologic options? We have Visco, PRP, and other blood products, cell-based therapies, placental-based therapies, and isolated growth factors. And we're going to focus today on not cell therapies, PRP. Is PRP the answer to everything? It might be if you look at these advertisements. So we have PRP for wrinkles, PRP for baldness, PRP for ovarian generation, PRP for all of the things that you see here, including fractures and tendon ruptures, PRP for joint problems, PRP for knee arthritis. Well, what can it really treat? What we think it can really treat is pathology of tendon, ligament, bone, articular cartilage, and maybe meniscus, and really tendinopathies and osteoarthritis. These are the keys with regard to standalone therapeutic use of PRP. Let's look at it from 30,000 feet. We have an injury, whatever it might be. We need growth factors to get to that site of injury, and then hopefully we get a repair. The goal of PRP is to manipulate the situation right here at the growth factor part. Now, we all make growth factors. Our body makes these. That's how, if you get a paper cut, you heal. It's not just platelets, there's growth factors. But that's the crux of this. We want to manipulate the body to bring more good growth factors to the site of injury. And what are the growth factors? Well, this is a non-exhaustive list, but this is a very important list of the things that we like and don't like when it comes to tissue injury. So we like proteoglycans, aggrecan, TGFs, BMPs, and IGFs. We don't really want the interleukins, the MMPs, or the TNF alphas. Those are the ones that can be challenging. So the goal of biologics, and in particular PRP, is to manipulate the intrinsic growth factors that are already present in our body and essentially make them a more favorable ratio for good growth factors versus bad. What exactly is PRP? Well, we all know blood. I'm going to take us back to med school for a sec. Blood is red blood cells, white blood cells, and plasma. Plasma is the non-cellular portion of blood. It contains platelets and growth factors, including some of the factors that I mentioned on the previous slide. PRP is defined by the American Red Cross as a sample of blood plasma with greater than 2 times the platelet concentration above baseline serum levels. That could be 2.1 times, that could be 2,000 times, that could be 2 million times. And here you're going to start to see the picture I'm painting with regard to the difficulties in understanding PRP. As long as it's greater than 2 times above your serum concentration of blood of platelets in the plasma, then you're called PRP. That is very variable and makes research very difficult. And so what do platelets do? Well, let's remember what platelets do. They have a normal biologic role for tissue healing. They contain growth factors and proteins, and the growth factors are going to be released from these alpha granules. And if you think I brought you back to med school already, wait until you see the next slide, because what we want to do with PRP is concentrate the platelets and thus concentrate the growth factors and proteins to promote healing at the site of injury. So remember those things called megakaryocytes? Those are the ones, those are cells in our body that produce platelets in the bone marrow. They have all of these structures, and we're not going to talk about all of these because we're orthopedic surgeons, but what we really want to focus on is the alpha granules. And these alpha granules within the platelets are responsible for essentially all of the goodness that platelets have to offer with regard to healing and tissue regeneration. And so that's what we're focused on, is these alpha granules. And these alpha granules release growth factors, and these are the growth factors that I mentioned before, but a more conclusive list or inclusive list of the ones that we really want. And some of the keys with regard to PRP and orthopedics include TGF beta, IGF, FGF. Those are the keys. But we can't forget about CTGF, which is a connective tissue growth factor, or VEGF, which is a vascular growth factor. And then when we talk about PRP's use in the skin, we're thinking about EGF, epidural growth factor, and KGF, keratinocyte growth factor. These are the ones that our dermatology colleagues are really using. And dermatologists have been ahead of us with regard to PRP for a while because of these growth factors released from the alpha granules of platelets. So the alpha granules within the platelets degranulate once the platelets are activated. So once there's an injury, the platelets are activated, or once you inject the platelets, we hope that they get activated. The activation typically occurs via a thrombin or calcium chloride cycle, and then growth factors get released. And TGF beta, when it comes to osteoarthritis, will induce chondrogenesis of bone marrow-derived mesenchymal signaling cells or stem cells. And then PDGF will aid chondrocytes in maintaining the hyaline-like chondral phenotype and promote proliferation and proteoglycan synthesis. So ideally, without a surgical intervention, in theory, if these work as directed, then these growth factors released from the alpha granules of the platelets that you've concentrated from the person's blood will hopefully turn in an osteoarthritic patient some of those chondral changes back into normal cartilage. That's what we hope. That's not truly what happens, but that's the goal. And so how is it used? Well, clinically, because this is important, our patient, you tell patients, I've got this PRP, I say sports magic. We've got this sports magic for you. They want to know, what does that mean? Well, what does that mean? So we draw peripheral blood, and the volume of blood that you draw depends on the system or company that you're using. And I'm not here to get into the pros and cons of different companies, but there are pros and cons of different systems. And then you place that blood into a centrifuge machine, and then you spin it per that company's protocol, and then you inject the concentrated end result of that, which is typically anywhere from 2 to 5 cc's, depending on the spin protocol that you're using, back into the area of interest. So this is an example of one that we use here at CU. This is from Arthrex. It's called the Angel system, or at the bottom, the ACP system. And I do consult for Arthrex, but not specifically related to this product. But this is one of the two PRP products that our university has chosen to go with, particularly for leukocyte poor PRP, which we'll talk about in a second. And so by the time you do all this and spin it down, you're essentially getting 3 basically layers of the plasma. You're getting plasma, you're getting your red cells at the bottom because they have a higher specific gravity, and then you're getting your buffy coat in the middle, and that's what we're focused on. The buffy coat contains the white cells and the platelets, and that's where, if you can remember one slide, remember this one. That buffy coat is where we really start to distinguish between leukocyte rich and leukocyte poor. So when we talk about PRP systems, what are the options? Well, let's keep this very, very simple, because that's how I like to think. So that's how I'm going to lecture. So simple preparations of PRP include plasma-based systems or buffy coat-based systems. Plasma-based systems are a single spin system. They typically result in less platelets per concentrate and also a lower amount of WBCs, or white blood cells. So in that buffy coat, it's less of both, but the key is to remember that it's less of the WBCs. And then when we talk about buffy coat systems, these result in 2 spins, which result in more platelets, so more of the items that we're looking for in some cases, but also more white cells. And so we have to be cognizant of that, because white cells can cause inflammation in the wrong environment. The keys to understand, as I just mentioned, is white cells can cause inflammation. They can degrade normal matrix through their own mechanism of action, and that depending on the clinical indication, more platelets is not necessarily better. And that's been shown in several basic science and animal studies. It's not like with PRP, the more you get, the better they're going to feel. There is an upper limit, and then at some point we can have diminished returns. So here's a picture courtesy of my buddy Jorge Chala at Rush, who some might know here because he spent some time here. And this is an example of what that buffy coat looks like, where you get the platelet poor plasma right in the center. And then again, the red blood cells are spun to the bottom because of their weight. And you can see that buffy coat is right in the center with the white cells and the platelets, and then the plasma is at the top. And we can use all of these fractions of the PRP spin down depending on the clinical indication. And so we just have to think about what we're treating and why. And this is where I think a lot of people kind of turn their brain off when they think about PRP. They're like, we're just going to put the PRP in. We really have to understand what we're treating and why we're treating, because it depends on if you want white cells there. It depends on if you want platelet poor plasma, if you don't really want the platelets, but you want some of the growth factors in the plasma. So this is a great paper, and because we only have a half hour today, we don't really have time to talk about this entire concept of leukocyte rich versus leukocyte poor. But when you see it in the literature, you may see it as leukocyte rich, which means it still has the platelets, but it's got an elevated concentration of leukocytes or white cells relative to the other type, which is leukocyte poor, which again still has the same concentration of platelets, but a lower amount of white cells. And so it's important to think about if the white cells are present, and then if there's fibrin present, and what that fibrin density might be. And this paper written by Lisa Fortier and Drew Lansdowne, one of my former co-fellows, he's out of UCSF and Lisa's out of Cornell, is a phenomenal review, very easy to read, very short actually. So I'd be happy to send this to anyone who's interested, but a great read on better understanding leukocyte rich versus leukocyte poor. And this is kind of how it comes out. So your rich PRP constructs are going to come out more red. This is very clear for both of these, but more red because of the white cells. The poor leukocyte poor PRP is going to come out. That's that more yellow appearing PRP that you see in clinic or in the OR, where the white cells have hopefully been taken out to the best of the products or the centrifuge's ability. Well, what system should you use? So this is great. I've talked about PRP. I've talked about how it works with growth factors and why it works. Well, what should we use? Because there's a lot of different options. I can't tell you. And unfortunately, I don't think anyone can tell you unless they're significantly biased by their conflicts. And that's because when you look at the literature shows that the variation of different PRP constructs with regards to the blood drawn, the platelets extracted, the red blood cells, the white blood cells, the pH, and the glucose is so variable that it's impossible to compare even one Achilles tendinosis study to another, because the PRP systems may be different. And thus it's like comparing apples to pizza. It's all food, but it just doesn't go together unless you like apples with pizza, in which case that analogy doesn't work. But the lack of standardization of PRP preparations for clinical use has really contributed to the varying clinical efficacy in PRP in the literature. And that's why we're having so much difficulty getting insurance to buy in, insurance to approve it, because for every study that you can find that supports PRP, you can find one that doesn't support PRP, and it's really hard to compare those two studies. Does PRP work? Well, when you look at PubMed, and this is a little bit of an older search because I think there's many more search results now, and this is a little bit of an older Google search, but in 0.38 seconds, you can see over 20 million hits when you search for PRP. When you see the literature, both in Google, which is what our patients look at, as well as in PubMed, which is hopefully what we're looking at, although there are some good sources in Google for physicians and and healthcare providers, and there are some good sources in Google for, in PubMed for patients too, but that's kind of how we divide it up. There's a lot of different PRP formulations creating a lot of confusion. We typically find that leukocyte poor PRP is beneficial for intra-articular problems, such as osteoarthritis of the ankle joint or of the subtalar joint, or osteochondral defects that you're trying to manage non-operatively, or potentially synovitis. And then when we think about leukocyte-rich PRP, it's generally best for soft tissue issues, such as tendinopathies. When we think about muscle issues, we're actually thinking maybe that leukocyte poor may be beneficial in the chronic state. It's really hard to say. And so even acute versus chronic tendinopathies and muscle injuries, there are some nuances, and we can't just label all of those as benefiting from leukocyte-rich PRP, because the acute phase of an injury may be very different from an inflammatory response perspective to the chronic phase of an injury. And then intra-op and post-op, it depends on the indication. In the knee world, there's a lot of discussion about using this with ACL reconstruction, meniscus repair. There's actually very good data to support meniscus repair with PRP over meniscus repair without PRP. I'm part of a multi-center trial that was supposed to start in Q1, but due to COVID, hopefully we'll start sometime this year, where we're doing a randomized controlled trial with or without PRP amongst multi-centers, but all with the same PRP, all with the same meniscus repair technique. And so hopefully we'll eliminate many of the variables that other studies show and get some very good data. But with regard to ankle, it's a little bit less conclusive, and I'm going to show that in a second. But here's where the confusion is. And when I present at knee meetings or shoulder meetings, I present these studies, for example, for osteoarthritis, and the ones at the top show that PRP doesn't work. And then the ones in the middle show that it does work. And then the ones on the bottom show that it might work. So it's really hard to get up to the podium and talk conclusively as a quote unquote expert about PRP when we can't even figure out from experts if PRP works. And so this is, whenever I'm making these talks, this was my dog last night, this is what my dog's thinking. Really, I mean, is this stuff really going to help me? He just had a spine injury, get my spine back to where it needs to be. And he's pretty skeptical. Well, let's look at the foot and ankle. So PRP and Achilles injuries. So I get this question all the time, even though I'm not a foot and ankle doc, and I don't see that many ankles. A lot of my sports patients have ankle issues, and then I send them over to you guys. But they ask about PRP. And I got to tell you, when you look at all of these studies, both from a non-surgical perspective, so if you're trying to have PRP augment non-surgical Achilles tendon rupture treatment, or if you're trying to augment surgical repair of Achilles tendon ruptures, no matter what you do, or sorry, for tendinopathy, I kind of highlighted the three things that I think come up most commonly. When you look at these three studies, which are published in pretty good journals, they do not show a helpful effect for PRP. Now, they don't show a harmful effect, but they don't show a helpful effect in terms of rate of return to sport, rate of healing, ability to recover, or patient-reported outcomes. So difficult to say if, for example, for Achilles tendinosis or ruptures, both from a surgical and non-surgical perspective, based on current evidence that PRP is helpful for Achilles injuries. So just something to have, and happy to share those resources with you. Why is the PRP literature so confusing? I mentioned this before, but my good friend Jorge published this paper a couple of years ago in JBJS. They looked at over 100 publications analyzing PRP with treatments all over the body, including for the Achilles, including for plantar fasciitis, amongst all of these other sites that you see here. And they found that a mere 12% of these studies, so just over 1 in every 10 study, reported on every processing step. So therein lies the problem. We don't know what these clinicians and scientists are doing because they don't report on it. And there's no consensus on the clinical indications, how the PRP is processed or how it's applied. Is it 1 injection? Is it 3 injections? Is the surgeon or clinician fenestrating the tendon or the joint with the needle when they put it in? Or is it 1 pocal? Is it an 18 gauge needle? Is it a 25 gauge needle? And do those factors matter? These are all little, is there local? Is there not local? We personally do not use local because we're not sure if the local anesthetic has any implication with regard to the alpha granules or deactivating the platelets. And so we don't want to mess with that. And so we just eliminate that variable, but then that creates more pain for the patient. And so there's a lot of questions, certainly more questions than answers. And there's certainly a critical need for standardization and consensus when it comes to PRP. So at the end of the day, when we think about clinical applications for PRP, these 4 indications to me are what I see as backed by at least some good evidence. And that's tennis elbow, and we typically use leukocyte-rich PRP, patellar tendinopathy, and that's controversial, but we use leukocyte-rich PRP, osteoarthritis, so for the ankle or subtalar joints or for any other joint in the body, we use leukocyte-poor PRP, and in general, for tissue inflammation, leukocyte-poor PRP. What does it not work for? Well, I'm sorry, guys, but it doesn't really work for Achilles tendinopathy, at least with what we know. It doesn't really work for cartilage regeneration, which is a bummer to me, but we're still doing studies on it to see if we just need to figure out how to get that PRP to talk to the cartilage a little bit better. Rotator cuffs, very controversial. There's more data for cells than for PRP. And then certainly can't help for any of these other things, such as the advertisements I mentioned, including improving your love life or baldness. So for anyone with those issues, there are other treatments, but don't waste your money on PRP. So take home points, and then we'll have a little bit of time for questions. There's still no consensus definition on what it is, other than what I mentioned regarding the American Red Cross saying that it has to be greater than 2 times the concentration of platelets relative to your blood plasma levels. Platelets and white cells play unique roles, but more of each is not always better, and you've got to know your indication. The growth factors are the key. It doesn't matter if it's PRP or quote unquote stem cells or whatever other injection. If we can optimize the growth factors in our own body, that's the key. It's more of a signaling cascade than anything else. And we can't just make a blanket statement of one type of PRP fits all. In fact, we had to petition to the university and to the hospital system to get us 2 different PRP systems because they treat different things. They can make concentrates that treat different things instead of a one-size-fits-all model, which certainly a big healthcare system would prefer. And then in general, leukocyte-poor PRP is best for OA symptoms and and inflammation, and leukocyte-rich PRP is best for tendinopathies. And with that, bundle up. Hopefully you all don't have winter rolls the way my pup does. And again, Dr. Hunt, thanks so much. That was 23 minutes on PRP, enough time for a few questions. And certainly later this year, we can talk about biologics in general. So thank you very much.
Rachel, that was perfect. Thanks so much for being with us. Perfect time, perfect coverage of the material. So thank you. While my colleagues are working out their questions, so you pointed out something that I think is really critical, and that is standardizing how we classify and administer, and probably as importantly, report on PRP. So you cited Jorge's paper on just sort of saying, like, here's the issue. It's not, we're not, back when PRP first started, we had one guy in Palo Alto who had a classification system, and we all sort of followed that, but now everyone's sort of moving in their own direction. So what efforts are being undertaken currently nationally to standardize this, or to have some requirement that it's reported in a standard way?
So great question. There are a lot of efforts nationally and internationally. I'm going to share my screen real quick. I do want to highlight. So this paper, this one is by Leprad and his colleagues, or Ian Murray, but really by Leprad, talking about this concept of MIBO, or MIBO, which is the minimum information for studies evaluating biologics and orthopedics. So I would encourage everyone, and I'm happy to send this PDF out, but to look at this and based on a Delphi strategy, a Delphi methodology, they sent out all these surveys to 23 experts from a few years ago, and they found a checklist, 25 items, in which has to be included in every study reporting on biologics, including PRP. And it's interesting. I was reviewing grants for AOSSM last or 2 weeks ago, and on the research committee for ANA, excuse me, our Arthroscopy Society, and Rob LaPrad's on that committee. And there was a Biologic paper, and I actually made a comment. I'm like, they don't talk about any of their methodology for reporting or standardizing PRP. I can't fund this study. And LaPrade wrote, correct, does not meet MIBO or MIBO. So this is really what I think we should be looking at. I think that there's some bias with what LaPrade thinks is important in here, but he did go through the Delphi consensus analysis. And so there's a checklist of 25 things. And I think it's up to institutions like we're doing here, which you're leading with our PRP registry, to make sure that we have all of these things and we are not missing a beat, so that when we publish, anyone else can go and replicate our study methods and get the same results. So that would be the goal.
That's great.
Great.
Yeah, so I should send that study off to you and to the team. I guess I probably should have done that before, but can send that study off.
Actually, if you don't mind sending both of those studies, the George's study and that one you just referenced, that'd be great. Mark, do you have a question?
Yeah, Rachel, that was an unbelievable, albeit brief presentation. And what I find is that there've been a hell of a lot of studies on PRP in the last, let's say, 8 to 10 years. But you alluded to it, the quality of the literature remains really poor because of methodology and outcome reporting. And there are a lot of basic science studies that do suggest that PRP has some beneficial effects on cartilage, but you can't compare across these studies because of a lack of standardization, whether it be study methodology, what are the contents of PRP, and I just don't know how you're going to overcome this.
Yeah, it's a great point, and I think it's very difficult. I think the keys are within your own institution, doing it the same way at every site. So if Dr. Hunt and Dr. Moon and I all treat I don't know, subtalar arthritis. Am I even saying that right? Is that it's still a thing? I'm just kidding.
There's a thing.
If we all treat that, and we all want to offer, PRP, we all need to be documenting, number one, all the things in that MIBO checklist, but number two, within the same institution, doing it all the same way. And I mean, same time of the day. If we're really getting to the nuts and bolts, same time of the day, because we don't know if the patient's blood, their peripheral blood that we're drawing, is impacted in terms of platelet concentration by diet, by hydration, by whatever. Now we hope that the PRP system can flush that out because it's concentrating things down. So we hope that those little things are irrelevant, but we don't know. And then I think once you do everything the same within, and that goes to rehab protocol, whether locals use, whether anti-inflammatories are used, et cetera. If we do that the same within the institution, and then we design multi-institution studies where all these parameters are the same, then I think we can start comparing, at least apples to oranges, if not apples to apples, but better than apples to pizza. But yeah, I think it's an uphill battle, in particular with biologics. And one thing we didn't talk about, but it's the elephant in the room, is the impact of industry on this. So industry is driving this, and the faster industry produces new products, the more difficult it is to study them. And the last thing I'll mention on that is there's a theory that one of the reasons that the literature is poor is because if the literature was better and insurance started picking up the bill, then the cash pay, out-of-pocket, profit-driven nature of the biologics industry would no longer favor the healthcare field. It would then just be like a steroid injection and be covered by insurance. And so there's some thoughts that maybe people don't want these products covered by insurance because then they can't make as much money as they're making. Now, I don't think that necessarily applies to most of us in academia, but in private practices, and in particular, the stem cell minute clinics, et cetera, where they're pure cash based, once this stuff starts being covered by insurance, they have to figure out a new way to make that cash. And so I don't want to start the conspiracy theory, but that is a theory that is floating out there in terms of maybe why there's not a bigger drive to make the literature better.
But it makes sense. And those people would constantly have to have some new twist, right? That's unique and special, that's better than the insurance covered PRP. Well, listen,
Yes.
I want to be respectful of your time. So thank you, Rachel. That was really fantastic. I really appreciate it. And then if anyone has follow-up questions, feel free to email them to myself or Rachel, as she offered to respond to those. So thank you, Rachel. Have a great day in clinic.
Thank you, you
And,
guys too, and I'll send those papers out.
Perfect. Appreciate it.
All right.
All right,
Thanks,
everybody.
Dr. Hunt.